going to go ahead and introduce Dr. Paula James. She's a grad from the University of Saskatchewan. She joined Queen's University faculty as an assistant prof in the Department of Medicine in 2004. She's now a full professor with cross appointments to the Department of Pathology and Molecular Medicine and Pediatrics at Queen's. She's the medical director of the Inherited Bleeding Disorders Clinic of Southeastern Ontario, as well as the Aligned Women and Bleeding Disorders Clinic there. She's had multiple leadership roles in our global community, our global hemophilia community. Her current areas of focus include evaluating the role of von Willebrand's factor in angiodysplasia, understanding abnormal bleeding in carriers, and translating previous works on quantitative assessments of bleeding into general community to increase the understanding of normal bleeding and abnormal bleeding. It is a brave new world out there, and Paula James is one of the people who's creating that new world.
Thank you, Pam, for that very kind introduction, and thanks to the organizers for inviting me to speak today. I'm going to show you some data, unpublished data from my lab, focusing on what we can learn about hemophilia carriers and their bleeding from studying desmopressin responses. So these are my disclosures. So as Michelle pointed out, the most famous hemophilia carrier undoubtedly is Queen Victoria. And so this is her statue in front of Buckingham Palace in London. This is me standing in front of that statue, looking slightly amused. And what was running through my mind as I was standing there was this. Seriously. And it feels sort of disrespectful of the crown to wonder that, but I really wonder what her periods were like. And so what I'm hoping to get at by looking at desmopressin responses in carriers is this question, which Michelle very clearly highlighted, which is, why do hemophilia carriers bleed? And as mentioned, what we know is that there are some factors that contribute, including the baseline factor 8 and 9 level, but that doesn't completely explain the bleeding because we see bleeding in individuals who have normal baseline levels. Our work has shown that age is a contributing factor. That just makes sense. The older you are, the more chance you've had to be exposed to hemostatic challenges. We also know that your VWF level and ABO status contributes, probably not independently. And so what we started to wonder was, how do hemophilia carriers respond to bleeding challenges or hemostatic stress, and might there be differences there that could contribute to the bleeding phenotype? So that brought us to consider desmopressin, or Ddavp, which many of you are familiar with. Ddavp causes release of von Willebrand factor from endothelial cells. And so the image here is a blood outgrowth endothelial cell that you can culture from a peripheral blood sample. And the green is von Willebrand factor. And so our endothelial cells are chock full of von Willebrand factor. And the way desmopressin works is to stimulate this cell to release that von Willebrand factor into the circulation. We also know that desmopressin increases factor 8 levels. Interestingly, I'm not sure we actually understand how that happens. Desmopressin is commonly used to treat or prevent bleeding. In this study, we're using desmopressin as a stress surrogate. So we're using desmopressin to stress or stimulate individuals and to see how well they respond to that. So our objective is to compare the lab responses to desmopressin in hemophilia A carriers and controls. And we focused on hemophilia A carriers because the desmopressin effect is on the endothelium, and that's where factor 8 is made. So this is a collaborative study between my institution and Emory University, Dr. Robert Sidonio, who has been very committed to the issue of carrier bleeding. So we are recruiting hemophilia A carriers at both centers. Robert could not get ethics approval to enroll healthy controls in the US environment, so we are only enrolling healthy controls in Kingston, and these individuals are screened very carefully to make sure that they have no history of thrombotic disorders. You can't smoke. There are a number of exclusions that we apply here to make sure that there's no potential harm coming to these volunteers. And so everyone who goes into the study has a desmopressin trial following our standard protocol. So we take baseline levels, and then we do blood work at 1, 2, and 4 hours after. So to date, we have 24 participants, so 17 hemophilia A carriers and 7 normal controls. You can see that our carriers are a little bit older. The median age is 34 compared to 21 in the carriers, and so we are trying to even that out with successive recruiting. As expected, you can see that the bleeding scores are higher in the hemophilia A carriers. Anything greater, 6 or greater, is a positive or abnormal score in a woman using this bleeding assessment tool. It's important to point out here, though, that we do have carriers with normal bleeding scores as well, which was an important group to include. And then there's no difference in the proportion of blood group O between our groups. And so I'm going to show you a series of figures here, and I'll do my best to walk you through them without being able to point. So I'm showing factor VIII level here on the y-axis, and the time points are across the bottom on the x-axis. So controls are in green, and carriers are in red. And the bar across the top with the 4 stars means that if you run statistics on this, there is a highly significant difference in the pattern of responses between carriers and controls. So controls get higher factor VIII levels, and they stay higher for longer. We were also interested, though, in what happens to a carrier who has a normal baseline level starting out. And so on this figure, I'm showing you just those carriers who have factor VIII levels above 50%, and we had 10 in the study so far. And so if you look at the y-axis and the note on the top that says NS, that means for this analysis, there is no difference in the starting factor VIII level between our carriers and controls. And despite that, the controls still get higher, significantly higher, at every time point after that. We thought perhaps this was due to release of von Willebrand factor, and it turns out that it doesn't look like it is. And so we compared von Willebrand factor antigen and activity between the carriers and controls, and you can see everything overlaps here. So there is no difference in the VWF response to desmopressin in these two groups. Then we asked the question, okay, what if we break down our participants based on bleeding score? And so would individuals with a normal bleeding score respond differently? And those individuals are in blue. Individuals who had abnormal or high bleeding scores or abnormal bleeding are in red. And you can see that an individual with a normal bleeding score responds to desmopressin better. So someone who has abnormal bleeding is not responding to desmopressin as well. So our conclusion from this study is that hemophilia A carriers, even those with normal baseline levels, have a reduced and less sustained desmopressin response. And what this suggests to us is that perhaps hemophilia A carriers don't respond as well to hemostatic stress, and that may be a contributing factor to bleeding. We have a lot more work to do before I could state that conclusion emphatically. We need more subjects, and so we are planning to continue enrollment until we have 40 hemophilia A carriers and 10 normal controls. We also need to think about why is this happening. It really challenges the way we think about the relationship between von Willebrand factor and factor VIII. And so we are planning some cellular studies in my research lab using those outgrowth endothelial cells I showed you earlier in the presentation, and then some additional cell lines that we can do experiments with. We are planning on doing multivariable analysis, trying to figure out how this puzzle fits together. And I have to say what I think is happening is that there are a whole bunch of factors that contribute your baseline factor level, the way you respond to a hemostatic challenge, your von Willebrand factor baseline level. I think that may end up being the explanation for why carriers bleed. I don't think there's going to be one explanation here. And then within my group, we want to continue to raise awareness and provide tools for women with bleeding disorders, which is a segue for me to show you very briefly about our Let's Talk Period project that Michelle mentioned. So this is the URL for our website. This is what the homepage looks like. I am very concerned about accurate diagnosis of bleeding disorders. And on both sides, I want to make sure that we don't miss anyone with a bleeding disorder, but also that we're not diagnosing individuals who don't truly have a bleeding disorder. And this issue was a concern of mine for a lot of years. And so one of the strategies that we decided to take to address it was to provide more information to the general public. And so we launched this website with information there about 1 in 1,000 Canadians has a bleeding disorder, but most don't know it. On this website, we've included an app for our self-administered bleeding assessment tool. So this is a series of questions that you can answer, and then you get a read based on the kind of bleeding that you've dealt with, whether or not your symptoms are within the normal range or whether you have abnormal bleeding and should seek medical attention. So we launched the website a year ago. There have been 14,500 page views. Over 2,000 people have taken the self-BAT. And of those, 60% have had abnormal or positive bleeding scores. And as I said, they would be advised to see a physician, and they get a printout that they can take along with them that shows what their results were. This has actually blown my mind. And so if you look at where the hits on the website are coming from, there have been 106 countries. Individuals from 106 countries have been on the site. We launched a matching Facebook page a couple of months after we launched the website. There are 675 followers as of this morning. This is not Kardashian level. But I will admit to being surprised that there were that many people who were interested in this. I think the bottom number here is the most astounding, though. So almost 110,000 people have seen our Facebook page. That actually blows me away. We have published a paper very recently on the process we undertook to decide how we were going to build the website and our first 3 months of activity. So if you're interested, you could have a look at this. I'm just going to end with a couple of acknowledgements. So the Desmopressin study that I showed you is the work of a master's student in my lab, Victoria Candy, who will be showing this work in more detail tomorrow at the HCDC meeting for those who will be there. Victoria is in the green. And then I also want to acknowledge Julie Grable, who's in blue at the back, who's the project manager for Let's Talk Period. CSL Behring is funding, with an unrestricted grant, the Let's Talk Period project, and we're working with a social media company from Toronto called Schmooze Media that I highly recommend for anybody who decides to get into the social media game. I'm going to stop there. Thanks for your attention.